Very good morning to all of you. And you're joining with Shri CPD program. Shri is a Society for Health Research and Innovation, and we're the national CPD provider, a program which has been running since 2021. So you're joining with the lecture number 237. So moving on to today's topic. Today's topic is about interventional radiology. And the topic is interventional radiology in emergency medicine, saving lives without a scalpel. And joining with us is Dr. Sathiyaseelan Maniharan, who is a consultant interventional radiologist from the National Hospital of Sri Lanka. So if I were to say something about Dr. Sathiyaseelan Maniharan, he is a board-certified consultant interventional radiologist with expertise in vascular, hepatobiliary, and neurointerventional procedures. He holds an MBBS from the University of Jaffna and an MD in radiology from the University of Colombo and advanced qualifications, including FRCP in UK. He is a holder of EBIR, the European Board of Interventional Radiology, and has trained as a senior clinical fellow in interventional radiology and neurointerventional radiology at King's College, United Kingdom. Currently, he serves as a consultant interventional radiologist at the Interventional Radiology Unit at National Epilepsy Center in the National Hospital of Sri Lanka, in where he's committed to deliver innovative patient-centered care. So we would now like to invite Dr. Sathiyaseelan Maniharan to deliver a CPD program on the interventional radiology in emergency medicine, saving lives without a scalpel. Over to you, sir.
Hello, good morning. Thank you, Tatsara, for that overwhelming introduction. So next 1 hour, I'm going to cover like interventional radiology role in emergency medical procedures, emergency medicine. So first of all, what is interventional radiology? So interventional radiology is actually one of the branch of radiology, but now it has gone beyond. Now, like what we do is like invasive, minimally invasive, image-guided procedures. We use different radiological image investigations like X-ray, ultrasound, CT, and MR for the guidance. So we treat different medical conditions without major surgery or major cut. So this is how in the right hand side you can see the image. This is how we take access to the. This is how we take access to the vessel. I'm like, you assume this is a vessel artery. Usually we take femoral artery, common femoral artery, or sometimes brachial artery, sometimes radial artery access. So you assume this is a vessel. What we do under image guidance, we put the needle in. Then through the needle, we will put a small wire. Then over that, we will put a gadget called sheath. So this is the end of the procedure. end of the end of inserting the sheath. This part of the sheath will be inside the vessel, and this will be outside. So now hereafter we deal. We manage all the vascular problems or interventional problem through this particular sheath. So there is no more cut, no more no more no more access. Only commonly we take one access and we deal through the access. So next question, why interventional radiology in emergencies? So obviously there is no major cut, so only a small hole in the vessel, and we put a small sheath, and then we'll do deal through the sheath, and this obviously is minimally invasive and less mobility. And patient, of course, like after procedure, they need to stay less than 1 or 2 days, and you can discharge very quickly compared to surgery. So less hospital stay, and success rate is very high. And also some areas, like you access, for example, if you say somewhere like in the thoracic aorta or somewhere in the abdominal aorta, sometimes it will be difficult to access with the surgery. It will be major, otherwise it will be major surgery. So you can easily access through the vessels by interventional radiology, and you can treat the pathologies. So these are the things I'm going to cover over next 1 hour. So mainly trauma and bleeding, and any acute bleeding non-related to trauma, and postpartum hemorrhages, stroke, thrombectomy, and acute limb ischemia, pulmonary embolism, and some other um, infective collections and pleural effusion and things. So we'll move the topic. So first of all, like this major topic is trauma. The trauma, like this is one of the major cause and leading cause of death in young population. So commonly injured organs, like commonly like liver, spleen, kidneys are commonly get injured. So what we do, like the patient presented to the ETU or accident and emergency unit. So if there is abdominal trauma, after initial stabilization, if the patient is stable, I'm like if the patient is grossly unstable, of course, you have to take the patient to the theater and do the surgical management. The patient at the moment is stable, you can do a CT scan. In the CT scan, we will be able to localize the site of bleeding. And if there is active bleeding, then of course we can go and intervene to stop the bleed. So indications are, as I told you, like recurrent hemodynamic instability despite resuscitation, and persistent hemophilia. Those patients we suspect there will be a fistula formation between the artery and the bile ducts, and repeated hemorrhages after initial surgical management. Those are mainly in like blunt trauma. Like if you take penetrating trauma, of course, there's high chance of bowel injury. So mostly those patients need surgical management. But if there is no bowel injury, if the patient is stable, still there's a small space for penetrating trauma as well. There are some contraindications as well, especially as I told you, the patient is grossly unstable, intractable hemodynamic instability. Then, of course, like the patient needs urgent surgical management because there's no time for CT and no time to take the patient to the interventional theater. And there are some related contraindications like pregnancy and high-risk patients like renal insufficiency, allergy, because like we are giving dye contrast. So those contrasts will be excreted by kidneys and they can cause allergic reaction as well. Of course, these are like a relative contraindication, not a absolute contraindications. So I will show you some cases. I think it will be more useful than go for theory. So this patient, this is a CT. You can see this is one middle-aged patient following RTA with abdominal trauma and abdominal pain. So this is the CT. You can see like you see the CT. This area you can see this hypodense area. This is actually liver. So this part is actually free fluid. I'm like fluid in the abdomen. It means there's bleeding into the abdominal cavity. So if you take the organs, you can see part of the kidney, part of the spleen, and if you take the liver, you can see there is grossly liver is lacerated. There are multiple laceration. If you look carefully, of course, you can see some focal hyperdensity, I mean, whitish area. It means, I mean, like we are suspecting there is bleeding or pseudoaneurysm from the hepatic artery. So, what we are done, we are taken the patient to the interventional theater. This is the right hepatic artery angiogram. You can see there from the one of the branch, you can see some contrast blush. It means it's like a what we call is a pseudoaneurysm. I mean, it's like aneurysm, it's like focal dilatation. Pseudoaneurysm means the bleeding has some like temporarily sealed off with a hematoma formation. So it will be, it's like a time bomb. It can rupture anytime and it can bleed anytime. So this of course like emergency. I'm like you can't keep it. So what we have done, we have gone into that. They are and we have embolized it. You can embolization mean we are blocking the particular abnormality of vessel with some embolic agents. We have different embolic agents, so we have blocked that. So that patient was completely recovered. This is a different patient, again, one of the young patient, road traffic accident. Patient with abdominal pain mainly over the left hypochondrium. This is CT. Still, as I told you earlier, you can see this free fluid. So the free fluid means there is bleeding. And you can see the liver. Liver, of course, there is no much bleeding or lacerations. You can see. You can see part of the pancreas as well, and the right adrenal gland, part of the left kidney. There's nothing major there. But if you look carefully into the spleen, you can see there is fluid around the spleen, and also there is hyperdensity, mean is bleeding from the spleen. So this is angiogram, splenic artery. I told you, we will take the access from the femoral artery or brachial artery, radial artery. So commonly we take femoral artery access. So after putting the sheath into the femoral artery, then we will have just called catheters and wires, like a small long tubes and wires. So we will advance those wires and tube into the abdominal aorta, like common femoral artery, then iliac, external iliac, common iliac, then abdominal aorta. Then we can, the celiac artery is coming from the abdominal aorta. There are branches, left gastric artery, splenic artery, and the common hepatic artery. So the initial case, I show you, like we are going to the common hepatic artery through the celiac axis. This is one through the celiac axis, we are going to the splenic artery. So in the splenic artery, when you do the angiogram, what we saw, there are abnormal pressures. Like you can see, this part is a bleeding point. So they are bleeding from the lower part of the splenic artery. So this is like we have embolized with coils. So this is after embolization, the bleeding has stopped. Patient will recover if no other major problem with the related to trauma. And this actually is not it's not a trauma. Actually, it's one of the post-surgical complication. This is post-PCNL. PCNL, percutaneous nephrolithotomy to remove the stones, will be done by urologist. So this patient underwent PCNL, post-stone extraction, and post-procedure patient developed hematuria. Then what we have done, the CT, you can see this enhancing part is a kidney, right kidney. So you can see the other kidney as well, how small is the kidney. So this is a large clot. It's a hematoma around the perinephric hematoma, and also you can see this pelvic system also filled with hematoma, and you can see the residual stones still. And if you look carefully here, you can see some additional density here. So again, the suspicious was bleeding. So this is same approach. We are going to the abdominal aorta, we are going to the right renal artery, and you can see right renal artery angiogram. So angiogram, you can see there is a pseudoaneurysm from the lower pole. There is a magnified view. Then we have gone with a microcatheter, like smaller catheter into that particular branch, and then we have embolized with blue. So you can see here in the kidney, only that particular small branch has embolized. Rest of the branch and like most of the almost 90% of kidneys are preserved. So that's a major advantage of interventional radiology. So only you can go selectively there, and you can embolize that particular small point of bleeding. So you can preserve most of the the soft tissue in the particular organ. This is actually a bit different scenario. Patient, like we got from cancer hospital. So this patient was, you can see CT. There's a large tumor. It's actually patient, lymphoma patient, was on treatment. Suddenly, patient developed abdominal pain. The hemoglobin has dropped. So the CT, you can see the tumor, but in addition, you can see there is a contrast density inside. It means there is bleeding from the tumor. So what we have done, we have gone again, with the CT, we are suspected for bleeding from gastroduodenal artery. That's why we need CT, because like when you do CT angiogram or CT abdomen or MR, you can see, like if you give the contrast, it will go all over the body and you can image any organs. But if you do DSA, so for example, if you are doing right renal artery DSA, only use the renal artery. You won't see left renal artery, you won't see splenic artery or gastroduodenal artery. So without knowing the site of bleeding, it will be very difficult, because like you have to go separately into each and every vessel. It take time, and also sometimes you will be missing the site of the bleeding. So here with the CT, we suspected bleeding from gastroduodenal artery. So we are going to the celiac axis. Then we are going to the common hepatic artery. The gastroduodenal artery is coming from the common hepatic artery. So then the angiogram, you can see there is a pseudoaneurysm. Also, it is bleeding. You can see the hypodensity black area is actually bleeding. So we have embolized that particular branch of bleeding site. I'm like we have seen mainly the abdominal trauma now. I'm like we are moving a bit like a different area like thorax. So this patient, trauma patient, actually he has fallen from height, and there he had multiple injuries like abdominal injuries and also thoracic injuries. I mean, if you take a CT also, you can see there are rib fractures and lung injuries. And if you look carefully here, you can see here some like a parrot beak-like things. You can see here. This actually a injury in the thoracic aorta, what we call aortic transection. It's a medical emergency, surgical emergency. Patient will bleed and die if you are not intervene as quickly as possible. So, like we have taken the patient to the theater, and so I will show you these are the images of the aortic transection. You can see here, and you can see here. You can see this sagittal section. You can see clearly that cleft. So this is how we are done. I'm like, we have again same access. I mean, this patient we have taken two access actually, one from the femoral artery and one from the left brachial artery. So from the femoral artery, I mean, like we have the angiogram. Still, we can see the defect. So we have put a, I mean, like it's a what you call aortic graft. It's like covered stent. So we have placed there, and you know that if you take this previous image, this is the defect at the subclavian artery level. So what happened like when you intervene it, of course, so we couldn't preserve the subclavian artery because the subclavian artery site is involved. So we have to cover the subclavian artery. So we put a stent across the subclavian artery. I mean, the proximal end is in between the left common carotid artery and subclavian artery. So subclavian artery got blocked. So I mean, like we know that it will get blocked. So what happened, like if the subclavian artery is blocked and if you cover this stent, what happened, like retrogradely from the vertebral artery and things, it will fill, and then this sac aneurysm will, so abdominal aorta will, thoracic aorta will fill retrogradely through the subclavian artery. Then the bleeding can continue. So what happened, we have taken the brachial artery access and we have come through that, and we have block the proximal part of the subclavian artery. In that case, what happened? The blood won't come retrogradely and it won't bleed through this. So we have put a stent graft and we have blocked the subclavian artery. And of course, like there's a risk of upper limb ischemia, but we will observe mostly some like most of the time like patient will maintain through the collateral and the vertebral artery, but like some there's a risk like like steel syndrome and things. But if the patient is some like they can't tolerate it, if the patient get upper limb ischemia, then they have to take theater and they have to do a bypass either from the left side to right side or brachiocephalic trunk to left subclavian artery to preserve the blood circulation. So this patient was completely managed with aortic stent graft, and no major surgery was indicated. Otherwise, this should be managed with a major thoracotomy and major surgery, even with that very high morbidity and mortality. This is again, I mean, like different sort of bleeding. Like in our setup, we have a lot of TB patients, pulmonary tuberculosis. So you go, I mean, like chest hospital, you will see, I mean, like quite a lot of number of patients with pulmonary TB and with hemoptysis. So what happened when there is pulmonary TB, there will be changes in the lung. So when there is abnormality in the lungs, especially like fibrosis or cavities or mycetoma or bronchiectasis, there will be abnormal vessel formation from the bronchial artery. You know, the bronchial artery is the artery supplying the oxygenated blood to the lungs. It comes from the descending thoracic aorta. So this patient actually presents with hemoptysis, post TB patient. So you can see there's a cavity, and there's the whitish area is actually what we call is a fungal ball. It's a mycetoma. So we have found the abnormality, and then we have done the DSA. Keep in mind, I mean, we are not doing DSA for diagnostic purposes. So DSA we do like during the embolization or during the intervention. Okay. So in bleeding, most of the time is embolization. Like we can put a stent graft, I show you like the previous case. We can put a stent graft. So there are different options available. So this is actually aortic descending thoracic aortogram. We have seen some hypertrophic vessel. So we have gone there into there, and we have done the selective angiogram. You can see this is actually right bronchial artery, or otherwise you call intercostal bronchial artery. So this is a normal artery, but got hypertrophied. And you can see these tiny areas of blood. It's actually these are abnormal vessels. It's formed around this abnormal area of lung. So these abnormal vessels are very fragile. It can rupture anytime and it can bleed anytime. So this patient bleed from these one of these collateral, even though we are not seeing that particular site of bleeding, we know that it's bleeding from there. So what we have done, we have embolized those abnormal vessels. You can see the like, proximal artery is still patent. We have embolized, but the abnormal vessels are not there, no longer there. So bleeding will stop. This is one of the interesting case. Actually, she's very young, like 18 years old, a female. They have found some tumor in the bronchus region. So what that they done, actually like bronchoscopy, they have biopsied. Okay, so after the biopsy, patient hemoglobin got dropped and patient had hemoptysis. So patient was a bit unstable. So we are taken to theater immediately. So this is a right bronchial artery, and the bronchial artery is not very hypertrophic. This acute thing is not very hypertrophic, but you can see it's bleeding from there. Unfortunately, I don't know the video. There is bleeding from that particular branch of the right bronchial artery. So we have, this is after embolization. We have embolized the bronchial artery. Patient was recovered well. This again similar case of post TB, cavity. No, it's not a cavity; it's a fibrosis, and you can see the what you call right bronchial artery hypertrophy and abnormal blood. This is after embolization. So if the bronchial artery, like these, if you take rather than embolization, if you are managing other way, I don't think like it will be easy to manage by other way, because like if you take the thorax, it is bleeding from this sort of small vessel. To reach that, you have to open the thorax. Then of course, if you even need to you often go to thorax, I don't think it will be easy to find this particular small site of bleeding. So even with the major surgery, sometimes you will be missing the site of bleeding, and there's a chance of failing the procedure. But like with the intervention, like you have almost 80 to 90% chance of going to the particular branch and embolize the bleeding site. So I'm like we are moving to other topic, limb ischemia, acute limb ischemia. Like as we are looking for emergencies. So what is acute limb ischemia? Due to any clot, like any thrombosis or any embolic phenomenon into the native artery or bypass graft, patient got severe sudden onset symptom or limb threatening ischemia. Then of course we can uh, intervene. And there are some contraindications, these acute limb ischemia, we will give thrombolysis. So, most of you will know what is thrombolysis. Thrombolysis means we give TPA, TPA altiplase, and then what happened, we lyse the clot. So these TPA, we are giving during the stroke and MI also. So it increases a chance of bleeding. So if there is a pre-existing condition causing bleeding, or any recent surgery, any recent stroke, any intracranial neoplasm, there's a high chance of bleeding. So you can't give this TPA. So those patients are, you can't do thrombolysis. So if the patient is, there is indication and there's no contraindication, then you can proceed it. So this is one of the case we have done. There's a video, I don't know, it's playing. Okay. So this patient present with sudden onset of lower limb pain. This is actually you can see the bone here. This is around the popliteal fossa. So this there is no contrast flow beyond the popliteal fossa, and there are small branches. There is no major collateral formation because it's acute. So still you can see the clots are there, and only the ATA distally reformed where some collaterals, and rest of the vessels are not there. So like below popliteal artery, there are only three branches: ATA, PT, and peroneal artery. So what we have done, we have passed a catheter there, and we are given bolus of TPA, and then we are given like we have started infusion of TPA or altiplase. Then we have done the angiogram, follow-up angiogram in 24 hours. So you can see actually it's a video. I can't play completely, but all three vessels has reopened. You can see this part was occluded and the thrombus all completely cleared up. And the ATA already was there, but ATA proximal ATA has reopened, and the TPA peroneal trunk and PTA peroneal artery are reopened completely. This is a distal angiogram. You can see the ATA and PTA coming nicely. So there are some risk and mortality because of this TPA, and it can increase the chance of bleeding. And also, these patients already have multiple other problems, so there's a chance of hemorrhage, stroke, puncture-related complication at the site of sheath insertion. Also, there's a chance of getting bleeding hematoma because of TPA. So there are chances of getting complication in 3 to 5% of patients, but still, you can preserve the limb. Also, like this is thrombolysis. So in some patient, we can do thrombectomy. So thrombectomy means you can take the clots out. So thrombectomy mainly we do in pulmonary arteries and also in stroke, intracranial circulation. So if you take pulmonary artery, the patient come with major pulmonary embolism, saddle pulmonary embolism. Patient, like you can't, unstable, you can manage conservatively. Then of course there's a place for thrombectomy and thrombolysis. But of course, like we don't have these thrombectomy catheters in Sri Lanka at the moment. But what happened, like we how we do thrombolysis, thrombectomy, we'll put a major catheter. Like the pulmonary artery, you have to puncture the vein, in the femoral vein. Then you have to go iliac vein, IVC, right atrium, then right ventricle. Then you have to go into the pulmonary artery. That's why we reach the pulmonary artery. So once you reach the pulmonary artery, then you can with the thrombectomy device, there's a device, you can take the clots out. Now we don't have thrombectomy device, so what we do, we put a catheter, what we call pigtail catheter, and then we rotate the catheter. So the catheter will degrade the clots. So you can, whatever you can, like remove the, like you can't remove it, you can move the clots from away from the major artery. So there's a chance of improvement. Also, there's a chance of complication as well because it can go distally and occlude the small vessels. So we do only in selected patients who are unstable, like who are like not responding to conservative management. Patient clinical parameters are unstable. Next sort of bleeding, that's one of the common scenario, GI bleeding, gastrointestinal bleeding. It can be upper GI bleeding, it can be lower GI bleeding. So, like how we manage upper GI and lower GI bleed. So, upper GI bleed, upper GI bleed, most of time it will be managed by endoscopists. So, what they do, they go with endoscopy and they find the site of bleeding. They block the site of bleeding. So intervention is indicated like in selected cases. If endoscopists can't control the bleeding, even if they can see the bleeding, but they can't control it. Or if they couldn't see the bleeding, or if the endoscopist or endoscopy is not available, then there's a role for intervention. So as I told you earlier, angiography, in upper GI or lower GI bleed or whatever bleed, angiography, is not indicated to diagnose the bleeding. Like CT, CT sensitivity to detect the bleeding is more than angiography. So if it is like, for example, like the bleeding is like 0.1 to 0.2 ml per minute, you can detect in CT. But if the bleeding, is up to 0.5 ml only, you can see in the DSA. So CT is must. So if you can see the bleeding in the CT, then of course, there's a chance you can find in the DSA and you can embolize it. If you can't see anything in the CT, of course, you won't see anything in the DSA. That's why we are not doing DSA for diagnostic purposes. So after finding site of the bleeding, we can go and embolize the bleeding site. So this is how the upper GI, the vessels supplied. Commonly, it will be bleeding from the left gastric artery coming from the celiac axis. Another site is coming from the GDA, gastroduodenal artery, coming from the common hepatic artery. And also it can come from the splenic artery and other branches as well. So these are the common sites. So we'll go there, and if there's site of bleeding, you can go and block that particular site of bleeding. There's a role of empirical embolization. Even though you are not seeing the bleeding, left gastric artery, you can embolize it. If you suspect bleeding from stomach and you can't see the bleeding, then there's a role. You can go with the intervention. Even if you can't see the bleeding, you can embolize the left gastric artery with a temporary agent. So there's a chance of controlling the bleeding. This actually one of the case. Patient with upper GI bleeding. The endoscopist couldn't control the bleeding. They have found the site of bleeding, but they couldn't. So, so this is celiac axis angiogram. This is anatomy I told you earlier. This is a common hepatic artery. This is splenic artery, and this is left gastric artery. You can see there's a bleeding from the left gastric artery. So what we have done, we have coiled that left gastric artery to stop the bleed. This again similar sort of case. This again bleeding from the left gastric artery. You can see like bleeding in the stomach, like a pseudoaneurysm like things. In the CT, this MIP reconstructed projection, you can see coming from the left gastric artery clearly. So we have gone there and we have embolized that particular left gastric artery. So how about the lower GI bleed? So we know the upper GI, I told you mostly it will be controlled by endoscopist. So lower GI, the colonoscopy or sigmoidoscopy, it will be very difficult to control the bleeding. So lower GI, there's a huge role for interventional radiologists to manage the bleed. Again, as I told you earlier, we need CT scan. So in the CT scan, you can you can find the bleeding site. This is what I told you earlier. So you can find the bleeding site and you can go into there and embolize it. But sometimes like this massive GI bleed, sometimes we do without CT scan, but still what happens, sometimes you will be missing the site of bleeding, and sometimes it take long time. So there's a chance of more bleeding during the procedure. So always if possible, better do CT and then take the patient to the interventional theater. Then that will be more useful, and it will be the surgery also very quick. And it's not emergency, but like in there's a low GI bleed, it's like very slow bleed. Of course, you can do RBC scan, then you can find site of the bleeding. This is the normal lower GI anatomy, superior mesenteric artery and inferior mesenteric artery, how supplies. Lower GI bleed, you can find site of bleeding and you can go there and embolize it. So sometimes, like when you go into the superior mesenteric artery, even if there's bleeding from somewhere from a small branch from the ileum, you go into the superior mesenteric artery and do the angiogram, sometimes you won't see that. If you go selectively somewhere there, only you will see if it's a small bleed. So that's why, like in the if you do DSA only, you will miss it. So this is one of the patient with a low GI bleed. You can see superior mesenteric artery. There's a bleeding from the branch of the superior mesenteric artery, and this is a different patient. This is again one of the other branch from the superior mesenteric artery. You can see the bleeding there. So these things, these patients, you can access into the particular branch through the small catheter, what we call microcatheter, and we can embolize or we can stop that bleeding points. So we have seen trauma, we have seen acute bleeding, we have seen lower GI, upper GI bleeding, and also we have seen some thrombolysis and thrombectomy. And this is other sort of bleeding, like maternal, like postpartum bleeding. So again, one of the most common mortality in pregnant mothers. So if there is a postpartum hemorrhage and they can't control by surgically, the patient like stable to answer to the interventional theater. Of course, what you can do, we can do uterine artery embolization. I will show you. Also, like in some cases, especially this placenta accreta spectrum. Placenta accreta spectrum, if there's percreta, there's a high chance of bleeding during the surgery. So you know that earlier, then you can place a balloon. like you can puncture into common femoral artery, and then you can place the balloon across both internal iliac or common iliac artery. Some cases in the aorta. So then you can send the patient to the theater. When they do surgery, they can inflate the balloon. So it will stop the blood circulation to the uterus. So they can do the surgery without much bleeding. Of course, they have to anticipate early, and they have to request this initiation earlier. But uterine artery embolization you can do after surgery even. So most common and most effective technique. We have more than 90% successful, and also with fertility preservation, because you can preserve the uterus. So this is how we go into the uterine artery. So you can see this is how we take the access into the common femoral artery. Then we'll place this catheter via into the internal iliac artery. This internal iliac artery, the anatomy, it will divide into anterior division and posterior division. So posterior division mainly supply the buttocks and the thigh, buttocks muscles and the nerves, mainly musculoskeletal system. So the anterior division, there are several branches. One of that is a uterine artery. So in this patient, you will see these uterine arteries hypertrophied in pregnant patients. So you can go into the uterine artery with a microcatheter, and then you can embolize that abnormal vessel. So there are different embolic agents available, so you can use that and you can embolize and stop the bleeding. So with that, you can preserve the uterus. And also you can control the bleeding. So I told you about thrombectomy in pulmonary artery, and also thrombolysis in lower limb vessels. This is the most one of the most effective and new method, cerebral thrombectomy in stroke. So if there is acute stroke, of course, we have indications. At the moment, we have indication if like more than 18 years old, and the neurological deficit would be mild to so moderate to severe, NIHS score more than 6. And initially, what we do a non-contrast CT, once the patient in the ETU. In the CT, what we look for, any site of bleeding. You know, the stroke 80% of stroke is um, thrombotic stroke, 20% of stroke hemorrhagic stroke. So if there is thrombotic stroke, there is no bleeding, it means it's thrombotic stroke. So then we know it's thrombotic stroke. So what we do, we go for, the patient is come within 6 hours, and the patient, clinically suitable patient for thrombectomy, we do CT angiogram. The CT angiogram, if there is major vessel occlusion like internal carotid artery, basilar artery, or middle cerebral artery, proximal segment, then there's a indication for thrombolysis, thrombectomy. And also in the non-contrast CT, in addition to see hemorrhage, we will see aspects score, to see how much infarct is established. If the infarct is established and there is no much salvageable parenchyma in the brain, then of course there is no point of doing thrombectomy, and there's a high chance of bleeding during the procedure. So we select the patient very carefully, and time window, usually within 6 hours, and if more than 6 hours, up to 24 hours, what we do in the CET, there is the body called the non-contrast CET aspect, so it's more than 6. And if you think there is salvageable parenchyma, then we do a MRI or CT perfusion. In that CT perfusion MRI, we can see how much salvageable parenchyma is there, penumbra, what you call penumbra. Then there is a significant mismatch. It means significant salvageable penumbra. Then we will go for stroke thrombectomy. So initially we do non-contrast CT to see the hemorrhage, and also to assess aspect score, and then we do CT angiogram to see large vessel occlusion, and some patients need CT perfusion or MRI. So there are some contraindications as well, as I told you. There is large established infarct and extensive ischemic changes, and like pre-stroke morbidity. And the patient, like even before surgery, before stroke, the patient in bedridden, or patient like closely depend on others. Then of course there is no indication. Obviously those are contraindications. This is how we assess the aspect score. So these are the areas we, in the non-contrast CT, we will see hypodensity in the nucleus like lentiform nucleus, caudate nucleus, internal capsule, insular cortex, and cortices in different location to assess the stroke extent. If there is, if, for example, if the caudate nucleus is involved, it means total score is 10. If caudate nucleus is involved, it means it's now. Now the score is 9. If lentiform also involved, the score is now 8. If the M2 also involved, score is now score is 7. So like that we calculate the score. If the score is less than 6, then there is no indication for stroke thrombectomy. So stroke thrombectomy, there are two devices, two major devices we have. One is aspiration sort of device. We can put a catheter. They are same thing. We go for femoral artery, abdominal aorta, thoracic aorta. Then we will go to examine the stroke in the right internal carotid artery, right middle cerebral artery. We will go to the brachiocephalic trunk, right common carotid artery, right internal carotid artery, then right MC. That's how we go there. So then aspiration device, there are aspiration catheters and pumps, so you can place the catheter and suck it, aspirate it, so it clot will come. Another device is like stent assisted device. I can show you here. For example, this is a clot in the MCA. So initially we will pass the wire and the small catheter will be called micro catheter. Then we'll take the wire out through the micro catheter. We'll put a stent like device. This stent, of course, you can keep you 1 or 2 minutes, then you can withdraw the, you can take the stent out. So with the stent, the clots will come out. It's what you call stent assisted stent retriever thrombectomy. This actually one patient we did it. So you can see right internal carotid artery, there is no circulation at all. It's completely occluded. Anterior cerebral artery, middle cerebral branches, nothing are there. So this is after thrombectomy. You can see now the old branches has re-established. What you call Tiki 3 flow. We have opened up completely. These are the clots we have taken out. It's very effective, but there are indication, and also we need the patient should be aware, because otherwise, most of the time our patients, the person after 6 hours, so the patient has to come immediately as possible, like when they got the stroke. These are different patient. You can see this non-contrast CT of a patient with stroke. It's very subtle. Non-contrast CT. As I told you earlier, we are doing non-contrast CT to see any site of any bleeding and also to assess the aspect score. You can see very subtle this internal capsule and this lentiform nucleus compared to the other side is hypodense. So there is a stroke here. So this is a CT angiogram. You can see the right middle cerebral artery, there is no flow. So this is the internal carotid angiogram, right side, the AC, anterior cerebral artery, and the PC, through the P comma patent, but middle cerebral artery are occluded. So this is with the stent assisted thrombectomy. We have taken the clots out. Patient will immediately improve. Whatever the deficit already happened will be there, but there will be no future deficit. Patient will improve immediately. Some patient they will immediately improve, like on the table they can elevate the limbs. So that's thrombectomy, and there are in emergency settings, so like urgent settings, there are we can do some ultrasound guided and CT guided procedure. Those are not vascular actually. You can do, if there is massive effusion or pleural effusion, you can put a small needle and aspirate it. And if there is abscesses, you can drain it, either ultrasound or CT guidance. And also like in kidneys and biliary system, if it is acute hydronephrosis or acute sepsis or acute pyelonephritis, the patient, the urinary system, PC system got occluded or blocked. They come with sepsis and high serum creatinine, high CRP and things. So what you can do, and ultrasound or fluoroscopic guidance, you can puncture the PC system and you can put a tube, what you call PCN tube, and you can connect to the back. So the infected urine or whatever the obstructed urine will come out, patient will improve. Same thing for the biliary system. If there is biliary obstruction, we have several pancreatic carcinoma patients, cholangiocarcinoma in our setup, and gallstone can also occlusion. So those patients, they can come with cholangitis. Cholangitis, it's one of the life-threatening condition. So you can put a tube, what you call EBD, external biliary drainage. You can puncture the bile duct and put a tube, and you can drain the infected bile. Also, in some patients, you can put a stent across obstruction, so bile can drain. So this you can see. This is actually the same patient. You can see we have punctured it, and then we have passed the catheter, and this is the stent. This is actually EBD. This is stent. Now you can see the contrast going into the duodenum. Also, you can train the abscesses, some more difficult abscesses also, like anywhere like pleura, lungs, hepatic. This is actually one of the pelvic abscess, post-surgical, anterior to the rectum after anterior resection. So we have done the CT guidance. Like this is called Ran's gluteal approach. We have put a pigtail to train the abscesses. And there's other sort of things, varicose bleeding. Um, like we have a lot of liver patients. So when there is liver bleeding, like varicose bleeding, mostly it will be controlled by endoscopist. But like if there is a recurrent bleeding or recurrent ascites, there's a role for tips. Like through the jugular vein, we puncture the jugular vein, then jugular vein will go into the SVC and right atrium. We will go into right atrium. Sorry, inferior vena cava, go into the right hepatic vein. Then we will make a shunt in between the right hepatic vein and the portal vein. So what happened when you make the shunt and put a stent on, you can see this is shunt. Now the shunt is in between the portal vein and the hepatic vein. Now the pressure in the portal vein will come down. So the bleeding and things will come down. But of course, you can't do in emergency setting like at the moment because of limited facilities. But like after endoscopies control the bleeding, if it is coming recurrent bleeding, still we'll be able to do the tips. Also, with the tips, you can embolize that abnormal portal hypertension site. This patient, you can see there is you see the rectal area, there is abnormal, you can see this hypertension, these are abnormal vessels, varices formation. So we have done the tips, and through the tips, we have gone into the mesenteric vein. You can see these abnormal blush, and then we have embolized the abnormal arteries in the perirectal area. So that's what we those are things I covered. So obviously the advantages I explained to you, because we can preserve the organs, and it's minimally invasive and life-saving in emergency settings, and recovery will be very fast because there is no major cut, and if you want you can repeat it, and less complication compared to surgery, and less hospital stay, less mobility. So there are several advantages, but at the moment we have some limitation as well, because we have very limited facilities, and interventional facilities are only available on a few hospitals at the moment, and we have very limited number of interventional radiologists as well in Sri Lanka. So we have limitations, but we will be trying to overcome, and probably like in future we will be doing more than this. This is what we expect. So summary, IR is minimally invasive, life-saving. In emergency setting, we can use in trauma, acute bleeding, stroke, postpartum hemorrhages, any abscesses collections. Also, like sometime like to get accesses like arterial and venous accesses. For example, arterial pressure monitoring and venous access for resuscitation, and also these biliary and renal interventions. And also, as I told you, any pleural aspiration, peritoneal fluid, you can put just a needle. In emergency, you can just put a needle and aspirate it. You can put a small cannula and aspirate it. And this is one of the very much like a rapidly growing field. Uh, at present we are doing like a lot of new things, but in future I think I hope that we'll be more than that, and hope to establish further, and try to establish a service further. Thank you.
Thank you so much, sir. Now we would like to move on to the question and answer sessions.
Yes,
today we have received more than 200 questions, so you won't be able to answer many of those, but we will try our best. So because lots of doctors, because it's a new field, there's a lot of quench for information on this field, sir. So we would like to move on to a few simple questions first.
Yes.
They would like to know what are the materials or the embolic agents used for arterial embolization basics so that they can get a general idea.
Yeah. That's a good question actually. Like we have temporary agents and we have permanent agents. So we commonly use like temporary agents, what we call gel form. I mean, like same thing the surgeons do during the theater, I mean, like surgical work, gel form. So what we make like a small pellets or like a liquid, and you can give that. It will work temporarily. But small branches will get occlude anyway. And we have permanent agents like coils. I show you one case. And we have used liquid agents like glue. I mean, it's like a permanent agent. You can, when the glue touch the blood, it will immediately clot it. And we have particles. I mean, like it's like a small, tiny pellets like things. It will be different sizes available. Those are the common things we have. And also there are several new things, plugs, and there are different agents available. But common things, these are the common embolic agents we use.
All right, sir. And then another question that we have received is how can we, what is the interventional radiological management for AVM and limb hemangioma? Sorry,
Yeah.
lymphangioma. Yeah.
It's not an emergency topic actually. It's
Yes.
again it's a vast topic actually. I can cover for one. So AVMs and hemangioma, I'm like it's a different spectrum. AVM, you know, like it's a arteriovenous malformation. So there will be artery, there will be nidus. Nidus means there is abnormal cluster of vessels in between the artery and vein, and then there will be venous drainage. So what we do in AVM, you have to go, I mean, like through that abnormal feeding artery, and you have to embolize that particular nidus, the abnormal circle, abnormal vessels. So I'm like it's like this abnormal vessel is like a tumor actually. Like if you are not embolizing the abnormal vessel and if you embolize just a feeding artery, this abnormal vessel will get supply from some other branch. So you there, I'm like if you just embolize the feeding artery, it means you are burning the bridge. So you can't just burn the bridge. You have to go into there and you have to embolize that particular abnormal site of bleeding, so abnormal site of the abnormal vessel, what you call nidus. It can be anywhere. We do in the brain as well. So anywhere, but there are some like important arteries, especially closer to the spine. There will be spinal arteries. In the brain, there will be some arteries supplying the vital area. So there are like related to the vessels. You will be careful, but of course you can embolize. Like endoscopy, you can manage it. Hemangioma is a bit different. It's a tumor actually. It's a benign tumor with a vascularity. So there will be no venous drainage. Like there will be late venous drainage. There will be no immediate venous drainage. So it's like a tumor with a high arterial circulation. So what we do, we go there and we embolize that tumor circulation. So we will go into the particular site of tumor and the artery. Then we go as close as to the tumor and give some particles or gel form, whatever. We embolize that tumor circulation. I think I have answered your question. Yeah,
Yes, sir. Yes, sir.
yeah,
Another
yes.
question that they have asked is, in an emergency situation such as a massive bleeding, how do we decide between whether to do interventional radiology procedure or go for surgery? So who makes the decision? How can
Yeah.
we?
At the moment, the indication wise, the interventional radiology is a dependent specialty because we don't have wards. I mean, we don't have like not like accident and emergency or ward setup. So at the moment, like worldwide, the indication the patient is grossly unstable, intractably unstable. Patient need like surgery. In trauma patient, bleeding, I mean, like patient needs surgery. But if they can't access like a bronchial artery or something, then of course they have to try to stabilize as much as possible and then contact the interventional team and arrange the embolization. But in trauma patient, if after initial stabilization or after initial surgery, or if the patient is stable at the moment, then of course there's a place to CT scan, and then if there is in the CT if there is active bleeding and pseudoaneurysm, there's a chance of bleeding because like so trauma, like bleeding can be from veins. Like for example, the pelvic bleeding, it can be from veins. So venous bleed, of course, you can't control by intervention. So mainly I'm like is surgical packing and whatever the conservative measures. So And also, as I told you earlier, like not like CT, DSA, you go into the particular site of branch only, you will see the bleeding. So you can't go. They will in pelvis, there will be maybe 100 of vessels. So you can't go into each and every branches. So if this patient grossly unstable, surgery, the patient after initial stabilization is okay, stable, or patient is stable, and you can do the CT. If you find site of bleeding in the CT, then there's a place for intervention.
Thank you, sir. And because this is a newly emerging field, there's a lot of enthusiasm about your specialty as
Yes.
well among the doctors. So,
Yes.
Dr. Shanti Jayasinghe would like to know, sir, does your specialty handle cardiac interventions as well, or is it purely interventional cardiologist role?
Cardiac, of course, like it's almost 100% will be done by intervention cardiologist. But aortic, aortic and aortic pathology, we can treat it. But cardiac mainly it will be treated by cardiologist.
Okay, sir. And then many of the doctors would like to know because we talked that there are issues with the availability of resources and
Hmm.
availability of specialists also in Sri Lanka currently. So
Yes.
they would like to know in which hospitals and which facilities can we get this specialty.
Like at the moment we have NHSL we have, but still like NHSL there are three interventional units available. So we are working and we have one core setup as well, but still there are limitations because these equipments are expensive. So it's not freely available sometimes. And if you take even thrombectomy, stroke thrombectomy, we have limitation in what you call the devices. So we have limitation, but at the moment we have facilities in NHSL, and also Jaffna we have interventional suit, and also we have one in Badulla, and Kandy we had, and we have the mission. I mean, getting replaced. It will be very soon. We are starting again, and we are trying to get in the process of course getting the DSM mission to Anuradhapura and Karapatia and Ragam as well. And I think Kalabu will also they put the machine already. So I mean, we are gradually establishing now.
Yes, and one last question to wind up, sir, because we talked about the AV malformations,
Yes.
embolization. So, one doctor has asked, what is like the success rate of AV embolization of AV malformation in the brain? Is it done in Sri Lanka? And if so, how are like the success rates like?
Yeah, AVMs, the brain, I mean, like is very one of the very common topic and like common presentation. With AVM can present with headache. It can come with epilepsy. It can come with ICH and bleeding. So there are indications like you don't need to manage like all the patient with AVM with the intervention. So there are indication to manage it. Even with that indication, like if the brain, these circulations, I mean, like brain arteries, like you take what do you call it, middle cerebral artery or something. One branch is supplying the AVM, it supply the parenchyma as well. Sometimes the area will be motor cortex, it may be sensory cortex, it may be visual cortex. So if you embolize it, there's a chance of getting complication as well. So we are very careful on selecting those patients. So it depends the expertise as well. Like even if you, when I was in UK, like mostly the embolization, the AVM will be managed by surgical team, neurosurgical team. But they said the surgical, what do you call it, the outcome is, I mean, like better. But in some countries, like both interventional and interventional radiologists and surgeons, we do. Here, I'm like, if we select carefully, I'm like AVM. There are, as I told you, like we sometimes one patient we do like a therapeutic curative embolization, a small one. There is no, like vital circulation to the major important areas. If you can embolize it, the AVM supplied one or two arteries. You can cure it with one or two episode of embolization. You can cure it. But some are like a very huge. It will be supplying all over there. Those is like what we call pre-surgical. Sometimes like with the surgeons, we combine and we embolize it and we give to the surgeon. They do the surgery. Some are like we call palliative embolization. We embolize only, like for example, in the AVM, there is an aneurysm as well. Like aneurysm, there's a chance of bleeding. Or there's a AVF, there's a fistula, there's a chance of bleeding. So we embrace the high site, high risk site. We are not embracing complete AVM because there's a high chance of getting complication, high morbidity and mortality. So depending on the patient and selection, it varies. But if patient is some curative embolization, you can the indication are there, and then if you can select the patient, the more the what you call the success rate will be around more than 80%. Any question? So finish to. Have I answered your question?
Yes, sir.
Okay.
So thank you very much, sir, for that very interesting session today. So we were joined by Dr. Sathiyaseelan Maniharan, the consultant interventional radiologist from the National Hospital of Sri Lanka. So now we would like to thank him for his excellent lecture and his precious time. And we have noticed during this lecture that it is a very vast area and an emerging area with lots of areas to discuss. So we sincerely hope you would be joining with us, Shri, in consecutive lectures, also to discuss very interesting and innovative areas in the fields of medicine. So, sir, with that, we would like to end the CPD session today. Have a good day.
Thank you so much. Thank you. Have a good Sunday. Thank you all.